So hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk, and I'm delighted to be introducing a mini-series entitled Fluid Matters. Recorded earlier in the year, we're running all 6 episodes to coincide with the 7th International Fluid Academy Day, IFAD, the International Fluid Academy Day. That was on November the 23rd in Amsterdam in the Netherlands. Top Med Talk was there. We did interviews, live streaming, roundtables, all that stuff we usually do, and generated more great content to add to our extensive back catalogue, which is now up to over 300 podcasts. More on that at the end of this from our creative director, Nick Majerison. Basically, if you want to get the 300 podcasts for free, completely free, you better act soon. So this is part 4 of our mini-series of 6 episodes entitled Fluid Matters. This is an excerpt from the Great American Fluid Debate, which was hosted at Duke University Medical Center's meeting, Controversies in Perioperative Medicine, held earlier this year. The debate is framed as restrictive versus liberal, but as you'd hear, these terms are questioned by panel members. How do the results of the RELIEF trial figure into this debate? Is the pendulum of progress swinging too far from overly liberal or too restrictive? What can research and detailed data around these questions tell us? Well, please do enjoy the debate, and if you look at the show notes within this, you'll see some papers and some references to earlier recordings that we've done on Top Med Talk as part of our catalogue of 300 or so, which include the results of the RELIEF trial, including interviews with Dr. Paul Myles himself. Top Med Talk.
Monty, thank you very much. So my role is to tee up the debate, not to have the whole debate. So I'm going to quickly run through the key elements of what I see as the key elements related to this restrictive versus liberal fluid therapy debate. And I'll start by saying that a massive problem is the terminology, but I'll just leave that out there because I think we'll come back to that during the debate. So as an opener, goals of fluid therapy. I suspect you, like me, when talking to residents, come out with expressions like this. These are our ambitions: maintaining an effective circulating volume, preventing inadequate tissue perfusion. But we don't actually know how to do that. We don't have effective measures, certainly in the clinical setting, of either effective circulating volume or tissue perfusion or actually fluid overload, certainly in the intraoperative setting in theatre. So the things we think we're trying to do, we may not be able to do as directly and easily as we sometimes imply. There's a number of ways of doing it. We're going to talk about the more patient-individualized approach later on. And what I'm going to talk about now is, if you like, the recipe-based approach. And the whole underlying notion of these restrictive liberal is that there's a right amount, typically expressed in mils per kilo, and you either give more or less. And the trend of the debate over the last decade and a half has been very much towards less rather than more. And it was driven by this study by Birgitte Brandstrup, published more than 15 years ago now, which showed in a relatively healthy group of patients, so colorectal surgery, almost all ASA1-2, in fact, there was a handful of ASA3s, all having epidurals in 8 Danish hospitals, so 172 patients, convincing demonstration that one group does better than the other, so less complications, less cardiopulmonary complications, better tissue healing. And the groups are called restricted and standard. And the conclusion in the abstract is all very clear. The restricted group do better, which is consistent with the results I've just shown you. And these are the volumes administered, and that's during day 1. So it's by first day, second day, third day, fourth day. Clearly not great enhanced recovery here. So during day 1, for all these trials, they're not helped by the fact that the time period that they describe for the administered volume always varies. It might be the first 24 hours, it might be the first day, it might be on PACU. But you can see there's approaching 7 litres in one group. And this is a group that had some starch preload at the beginning of surgery. They had some crystalloid to make up for so-called third space losses in contrast to the restricted group. And the consequence was a lot of fluid administration. The other group got about 3.5 litres, between 3.5 and 4 litres. Now, the interesting thing from a UK perspective, and it's hard for me to speak to a US perspective at that time, but we had goal-directed fluid therapy studies where both the intervention and control groups received between 3.5 and 4 litres. So the notion that the tall bar there, the nearly 7 litres was standard, didn't really fit for us. Notwithstanding that, it was a strong message that restricted fluid therapy was supposed to be better. And this was followed through by a number of studies, which was summarised in this systematic review and meta-analysis by Paul Myles group with Thomas Corcoran as the first author, which was the preamble to the relief study, which I'll come on to in a moment. And the overall summary of this systematic review was that it looked like restrictive fluid therapy was better. So the relief study was planned on the notion that they would prove that restrictive fluid therapy was better than a so-called liberal approach. This is the mortality data, not statistically significant, but consistent with all the other forest plots for length of stay or various types of complications, which all had a signal in favour of so-called restrictive fluid therapy. Now, we're talking about the balance between inadequate fluid, the risk of potential failure of tissue perfusion versus excess fluid and edema and all the problems that come with that. And I think we've been on a journey from potential excess, arguably towards the middle ground or possibly towards inadequate. And what we clearly know is that the relationship between administered fluid volume and effect is not like that. It's a bell-shaped curve. This is, if you like, the inverse of the classic Bellamy curve from 2005. So we've got a notion that there's a good effect and a notion that there's a bad effect. And clearly, if you manage to target your restrictive group on the top of that bell-shaped curve, restrictive will look better. So that's the recipe that you choose in contrast to liberal. But of course, if you chose a slightly different recipe, you could have a liberal group that looked better. And in fact, that's what the literature looks like. So there's a study by Catherine Holter, for example, in laparoscopic cholecystectomy, where the liberal group would do better. It's a difficult literature to interpret. And part of it is because the recipes are only recipes, and all of us know that we give fluid, at least in part, in response to how the patients are. So if you look at the studies, there is huge variation in the total volume of fluid administered, reflecting the fact that we tailor our fluids in part to the patients. And of course, there are huge volumes of differences between patients. So if you like, patients come like this. So for any particular target recipe, it's going to be a rather difficult thing to match it to every patient. So I have a problem conceptually with the notion of these recipe-based approach, but they do give us a frame of reference as to what might be too much and what might be too little. And certainly Brigitte Brandstrup's paper suggests that approaching 7 litres, not surprisingly, might be too much. Surely not everybody does that. Well, we've had some really intriguing epidemiological data in the last few years looking at large populations and the volumes of fluid administered, and they give some very interesting clues as to why we give fluid, not why we think we give fluid, but why we actually give fluid. So this study from Maxine Cannison's group, 2 large institutions, more than 30,000 patients, simply describing how much fluid was administered for major surgery. And you've got this big scattergram, and they did a very complex regression analysis looking at all the possible factors that one might imagine, from blood loss through length of surgery, etc., etc. And the single thing, or the single factors that are the principal determinants of how much fluid you get during surgery are who gives it. So not blood loss, not duration of surgery, not even type of surgery, but which anaesthesia provider and which surgeon, anaesthesia provider most important, surgeon second most important, walked through the door on that morning. And that again is disturbing to me, because you'd imagine, and we say, I think we all imagine, that actually it's to do with the blood loss and the duration of surgery and the type of surgery and all those things. What that sort of epidemiological data has also given us, and this is another big data set analysis with Julie Thacker leading, Monty involved, looking at literally hundreds of thousands of patients and the scope of what was prescribed. Now, I won't show you the detailed data. The detailed data suggests there are patients who are getting as little as 1 litre of fluid for major surgery and as much as 22 litres of fluid, but you can divide them up into groups based on which quartile of volume of fluid administration they received, and then you can look at the outcomes, and it turns out, if you look at cost as a summary measure of outcome, that bell-shaped curve is replicated. There appears to be an area in the centre of behaviour, so the middle 2 quartiles, where the costs are least, and if you give less than that, arguably an inadequate amount, the costs go up, and if you give more than that, the costs go up. This is for nearly 100,000 patients undergoing elective colorectal surgery. Similar data for more than 500,000 patients undergoing hip and knee replacement, exactly the same sort of signal. So there is a middle ground, but it's slightly vague in this sort of analysis where the middle ground lies. So we've got a reasonably big range between 1.7 and 5 litres with a median of about 3 litres that looks like it's broadly the right target. Which brings me on to relief. Biggest and arguably best conducted randomised control in this area to date, led by Paul Myles. He did the systematic review I showed you earlier as part of the preparatory work, along with a lot of other work, with the aim of demonstrating that restrictive fluid therapy was better. The liberal group received 10 mils per kilo as a fluid load of crystalloid, balanced crystalloid, at induction of anaesthesia, and then 8 mils per kilo following that. The restricted group received 5 mils at induction and then 5 mils following that. And the aim of the restricted group was for a neutral body weight, so no increase in body weight, which had been the declared aim of the restrictive group in Grocott study. These are the administered fluid volumes. So you can see in the restrictive group during surgery about 2.2 litres, in the liberal group about 3.5 litres, and a median fluid balance shown there, but probably the most intriguing thing, the median weight gain. So the restrictive group achieved the goal of essentially no weight gain, 300 grams, and the liberal group had a weight gain of about 1.5 kilograms. So not too scary, either of them. And if you look at the results, their expected outcome, which was a reduction in this relatively new measure of disability-free survival at 1 year, was a benefit for restrictive, but in fact there's no difference between the groups on the primary outcome variable. But what really has interested everybody are these renal results, which show in the group that had a bit more, not the restrictive group, in the group that had a little more fluid, better outcomes both in terms of reduced acute kidney injury and acute reduced renal replacement therapy. So arguably something of a surprising result in the perioperative setting. If we look at where that sits when compared with the epidemiological data, arguably the liberal group is pretty close to the centre of the target. The restrictive group is just falling off the bottom of that target group. And I think this gives us a useful check on what might be going too far in terms of restricted fluid therapy. So to tee up the debate, my closing messages are clinical practice is chaotic when we look at it. We are extraordinarily varied in the way that we prescribe fluids intraoperatively. Recipe-based fluid dosing, so when you read these sort of mils per kilo protocols, it's always individualized because we always respond to what happens to the patient during surgery, and we're always a little bit more nervous for the patient who's got heart failure than those that haven't, etc. So they need to be taken with a pinch of salt. Enhanced recovery has driven a lot of the fluid restriction story, but the wording at the beginning was always avoidance of fluid excess, and it's been translated into fluid restriction, and I think that's been unhelpful. And relief offers us a pretty useful target at the moment. It's, I think, the best we've got, of aiming for something like plus 1 to 2 kilos of weight gain as a target for your fluid balance during surgery. Thank you very much for listening.
Right, Mike, that was excellent. What a great setup there. I just want to get some initial comments. Actually, Paul, I'll start with you, if I may, because you're out on the floor more often than the rest of us, doing your nutrition rounds, etc. Is the scary messages about fluid balance? I know it's not like that at Duke, but other places you've worked, is it a real thing?
I think it's definitely a real thing. I think in all the institutions that I visit and have worked in, it's a huge challenge. I think, and you see the extremes in both directions. I think I see it the most when I'm functioning as the surgical intensive care attending, receiving patients from the operating room, where you'll see patients that have been run very, very dry. Perhaps on that side of that last study you just cited that leaned to the renal failure, where we've taken maybe ERS and fluid balance too far the one way. And then, of course, we still see the patients that come in that, the resident left the little wheel open and they got many more liters of fluid pops than they ever would have needed. I think the other piece I see is a lot of chloride. I think I see enormous amounts of hyperchloremia both at Duke and in Colorado. I think Plasma-Lyte, and this is now my opinion from watching lots of patients come through, places that use Plasma-Lyte as a standard fluid have much less hyperchloremia, where I see it routinely when lactated ringers is used. You'd think that small amount of chloride would make a difference. And chloride is essential because chloride is what injures the kidney. It's very expensive to pump for the kidney. It uses a lot of ATP, and so hyperkalemia is not this annoyance that we think it was when you listen to the great renal doctors. They'll say, no, chloride is really a stress to the kidney to pump. And so hyperkalemia should not be taken lightly.
Stuart?
So this whole framing, what is liberal, what is restrictive, we have our enhanced recovery protocol, and one of the questions Tim and I wondered was, does enhanced recovery protocol increase your risk of kidney disease? Now, we didn't call it liberal or restrictive. We looked at our goal-directed enhanced recovery policy, which maybe, when I actually look at the fluid that we gave, we're in that in that sweet spot. But we could find with our protocol no increase when we looked through our change in practice from an eclectic fluid administration to enhanced recovery. We couldn't find any increase in the changing creatinine, which is...
And on the diagram, so the FRCA diagram or whatever you want to call it, where would you sit on that? Are you in the middle of the shaded area? Or?
So we're sometimes in an enhanced recovery protocol in the middle of the shaded area. Sometimes it turned out, when you carefully looked at the amount of fluid given, we had within our protocol, sticking within the protocols, and another debate, how do you stay within the guidelines? But yes, the majority of our patients were within that sweet spot in the middle.
And Tim, so the difference here, I think, is that is heavily protocolized and mandatory use of monitoring to help people make the right decision. Is that right? Because
yeah, absolutely. And I think there's two key points. I think, when I first arrived in the States at Duke, which was about 10 years ago, patients having major abdominal surgery, it was 2 IVs, it was drip on both sides, and you would see CRNA resident by the end of the case, 5-6 hours, circling 7 or circling 8. And these patients were getting 7 or 8 litres of fluid, and that undoubtedly is harmful. And just imagine if you are, as in the Brandstrup Liberal group, you are 4 or 5 kilos heavier the day after surgery than you were the day before. Imagine how that is. Imagine 4 or 5 kilos of fluid being given to you. These patients obviously felt edematous and had slow bowel recovery.
So that's a litre, I'm guessing. That's a kilo.
Yes.
Ignore the glass. So you got 5 of those. But the real killer is not the water, is it? It's the salt.
It's the salt that goes along with that. So you retain that water. It takes you a long time, 3, 4, 5 days to get rid of, and maybe longer, to get rid of that salt load. So that undoubtedly is harmful. And Stuart said we changed to a goal-directed approach, which we'll talk about later on. So
pause for 1 second there, Tim. How much salt is there in there's a bit less in plasmolite or Hartmann solution, but broadly speaking, they're isotonic with a normalish salt level. How much salt is there in a litre of saline?
So it's 150 millimoles per litre, which is the approximately salt in about 12 bags of Walker's crisps.
Let's go to Lay's big bag grab. It's 25 bags of Lay's big bag crisps, salt equivalent per litre of saline. So 0.9% solution, 9 grams per litre. So that's 2 days of salt per litre. So 5 litres is 10 days of salt you've just given that patient has to handle, and you can only pee half normal saline. So it might take you, if you just pee half normal saline, it might take you 20 days to get it out.
And you're having various stresses that are trying to reduce your urine output, such as the surgery itself and the stress response to surgery. So that undoubtedly was harmful. And we went to a goal-directed approach, but going around the country listening to people speak about enhanced recovery, the real restrictive fluid therapy has become, or did become before relief, in my opinion, more and more trendy, cool. People were saying, I only give 1 litre of fluid for my colorectal procedures, and someone else will be, we only give 500. And I actually had someone that came up to me and said, I don't give any fluid. I think this was actually in the UK. They were saying, the patients get their preoperative carbohydrate drink. I've got a really good surgeon. He takes an hour and a half for his laparoscopic right hemicolectomies. Patients drink in PACU, so I just have an IV, but I don't have the fluid running. Our patients don't get fluid apart from to give drugs. And that became, very cool. That was the cool way to do things, giving less and less fluid. So we tipped, as often is the case, from one side right the way to the other in a lot of places.
But so I think we've got to appreciate there's been a lot of benefit in the journey. So we see less lung injury in critical care now in post-operative patients. We're seeing patients getting out of hospital quicker within ERAS. It's just, as with many things medical, we swung the pendulum such a long way. I mean, so for example, we a couple of years ago started seeing for the first time elective major joint replacements getting filtered. We've just never seen that before. But the restrictive protagonists were so enthusiastic, and they were still throwing in their non-steroidal, that we were getting occasional significant renal injury requiring renal replacement therapy. And I think you saw on the national data...
Yeah, you could see a blip. We can't know if it's cause and effect, but there was a national blip in acute kidney injury after major surgery. The possible unintended consequence there is somebody interpreted don't fluid overload them and called it restriction, and the people who couldn't be bothered to goal direct ran with that because it's easy. I'm just going to give less. I'm just going to guess less rather than guess more. And then you add to that round-the-clock non-steroidals and restarting your ACE and ARBs. And basically, man, what a perfect storm from the point of view of driving acute kidney injury.
It's interesting that, I know you know Brigitte well. I just met her last year, Brandstrup, but she really regrets using the term restriction.
Yeah.
She really meant avoidance of fluid excess. That's what her paper tried to show. But she coined this term fluid restriction, and I think it's been a very confusing term because you associate fluid restriction with, really deliberately causing hypovolemia, really going restrictive, and that's harmed.
And she then, it's not a Brigitte thing, did fantastic work and brought us to this place. She then changed that to zero balance. Now, not everyone was happy with zero balance because when you goal direct, you typically end up about +1, +2, not at 0, which is the relief result. And that seems to make sense because you get an inflammatory reaction just from inducing anaesthesia. You lose some of the glycocalyx, the bucket gets bigger, vascular tone changes. And even if you do it absolutely perfectly with the best technology in the world, you're landing somebody perfectly, you land them at +1 to +2. So our national guidelines, we said +1 to +2 is okay. Actually, it's possibly something to celebrate. +3 is a failure, and zero balance is possibly a failure.
So Monty, one point I'll make too, you're used to a culture of all ERAS-driven patients. How many of you do pre-op carb loads and ERAS MPO periods at your hospital?
So 3, 4, 5, 6,
I'd say
7,
about
8,
10%. So we have a deficit in the U.S., right, when our patients come in as well, which challenges us. Our patients are MPO 12. We know from MPO studies the average MPO period of a patient having surgery is about 18 hours. So when you total it up, because of delays and other things.
That is one thing that gave people confidence, was belief that they were coming hydrated and carb-loaded, which, yes, sometimes they were, but you can't completely rely on that.
For sure.
You can't rely on people to definitely drink the fluids. I think you still have to be just a little bit generous. Now, if people want to dive in on this, please start to get your hands up. I'll get a microphone to you. Yes, sir. Welcome. Mark, is it, yeah?
Mark Hansen, Baltimore, Maryland. For restrictive fluid, a lot of our GI patients are getting the bowel prep, their NPO overnight. They're telling us to restrict fluid less than 2 liters per patient, but a lot of our patients are not urinating. So I tend to push a little bit more fluid just to try to get urination, the 30 cc's an hour, just something to come out. But the surgeons are all on you gave too much fluid. Do you guys have a comment about that? Should I be looking for that or just not?
Show them the relief study, I think.
And the comment,
you got an article in the New England Journal to back up your practice that too restrictive can cause harm.
Yeah, and that's the silent killer, isn't it? The acute kidney injury. They're running them dry. They can breathe well. They may go home early, but if you look at the Mass General data published, was it last year published? they ended up costing more money because they ended up with a silent killer, which is the acute kidney injury. I'll come to you in a second. So we've got one question back here.
And just finding where you're going.
Penultimate question on this section.
The other just piece before you go is, and the type of fluid really matters, right? We have the Todd Rice paper of the New England Journal that the kind of fluid you give, normal saline versus a balanced salt solution, really makes a difference. And that was a very large, well-done trial in 2 different settings, OR and ICU. So I think we really need to get away from normal saline, maybe even LR.
Muriel Manlapas, Cleveland Clinic. So for the most part, I think most of us just want to be 1 to 2 kilograms positive at the end of the day. The bottom line is we really still don't have a perfect measure for goal-directed therapy. You go for an abdominal surgery, and then now you go for a scoliosis surgery, and with the MEPs, you really have too much artifact to really figure out a good monitor for goal-directed therapy. So then, you also don't have a really exact measure of blood loss, right? So at the end of the day, you're still guessing a little bit as to, response to fluids. So most of the time, people do normal saline and then mix it up with albumin, which really has the same solute or sodium concentration than normal saline. So then, sure, we want to do this. We want to just be 1 to 2 kilograms up at, after surgery. But guidance, what should we do when, say, for example, albumin, we get more bang for our money. We really get more, response than just giving, again, normal saline. But albumin that hasn't been shown to show benefits, right, over normal saline. So really, where should we go to get this 1 to 2 kilogram balance at the end of the day?
I mean, one thing I would say, I think that the whole restrictive liberal approach is misleading, because if you look at those studies and you look at the volumes of fluid administered and the standard deviations, for example, they're 1.5 to 2 litres. So the takeaway message might be give 10 mils per kilo at induction, 5 mils afterwards, or whatever the particular recipe is. But that's guiding the target zone, but it is not what's actually happening to the vast majority of patients. So the therapy is being individualised. It's a question of how you can best individualise it, as opposed to, I think, it makes me very nervous, the recipe type approaches, because they, even in the trials where they're apparently being done, they're clearly not.
And sorry, ma'am, do you, when you say normal saline, do you really mean normal saline, or do you mean an isotonic? Because I thought that's the one. Hang on, I was saying, I thought that's the one thing we finally had an answer to in the biggest studies I've ever seen. 27,000 patients in total from Vanderbilt. It's not an RCT, but the saline is clearly associated with the worse outcome. It doesn't make any sense physiologically. It increases mortality in animal studies. Why on earth is anyone still doing it?
I agree, and I think
it's not an either or. It's not all.
If anyone hasn't seen these studies, they were published in the New England Journal of Medicine, and clearly showing that you get a hyperchloremic acidosis with saline that is bad for the kidney, increased acute kidney injury, and lactated renins is no more expensive than saline, and so we do not use normal saline in the operating room.
I'll get the link up for people. I interviewed Andy Shaw, one of the authors, for about half an hour on Top Med Talk and went into all the detail related to it, so that's all there for people to listen to and share with friends. Thank you very much indeed to our wonderful panel, and thank you to you for participating in this discussion. Top Med Talk. So some clear take-home messages there. Don't restrict. Do goal direct. And if you go into our search engine again on Top Med Talk, once you've listened to the relief articles, you can put in fluid restriction and or put in goal directed, and you'll get some more podcasts recorded on those subject areas. And within the articles, there'll be papers that will link you into different information if you want to dive deeper into these subjects. Also, at the end there, we touched on the balanced versus saline question, and I said that I would put a link in there to an article I recorded under the guise of Journal Club, Balanced versus Saline, with Dr. Andy Shaw, one of the lead authors of that paper, regarding the 2 studies published in the New England Journal of Medicine from Vanderbilt University. So, if you want to get involved in these debates, please do come and join the Top Med Talk team. We'll be live at the upcoming EBPOM London meeting coming up at the beginning of July. Go to the website ebpom.org, and you'll also have a chance there to meet Paul Myles, that we've been referring to about relief, along with a large international faculty where, along with other matters, we'll be talking more about fluid. We'll also be celebrating the 70th anniversary of the NHS. So, www.topmedtalk.com for the podcasts and ebpom.com for the meetings. Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk Fluid Matters. Don't forget, if you get yourself onto the internet now, you can download our entire back catalogue absolutely free of charge. We're itemising it and categorising it at the moment. It may not always exist in that form. We highly recommend you get yourself to the internet now, either via the Top Med Talk website, topmedtalk.com, or you go via your podcatcher and you dig out our entire back catalogue, get it all on the hard drive, and then you own everything we've ever done. Also, don't forget to subscribe to Top Med Talk. That's vital. And whilst you're at it, have a little look on social media where you can find us on Twitter, LinkedIn. We've even got our own YouTube channel. Obviously, we're on Facebook. We're all over the internet. Find us, subscribe to us, and join us online. And whilst you're doing that, get to the website and get on that mailing list of ours. We have a brilliant email mailing list which keeps you up to date with how you can get more involved in Top Med Talk, including, of course, some of the meetings that we attend. And if you want to find out about those right now, go to ebpom.org/meetings. Then you can see all of the big events that Top Med Talk and the team are going to be at in the near future. That's ebpom.org/meetings.